Okay. Good morning, everyone. We're going to get started. Uh, my name is Dr. Ellen Rudy, and I'm going to be moderator and participant today. A little bit about me: I'm a white woman with straight brown hair that's slightly frizzy because of the humidity in Washington, D.C., wearing a white top. I go by the pronouns she and her. Um, I'm an epidemiologist. That's my background. And I actually started my career working in a safety clinic in Hollywood, California. It was a Los Angeles Gay and Lesbian Center. And I learned a lot about access to care there and about vulnerable populations. I then worked in public health. I worked and did a lot of contact tracing, developed that program in LA. And then I moved over and worked in a Medicaid managed care company where then my focus was really trying to help moms and kids and low income people get primary and preventative care. And then some people say I joined the dark side. I joined a small healthcare startup company. It's not the dark side. It's not me sending you, by the way, emails 3 times a week. But I did that because the small companies are uber focused on solving a certain problem. And for me, I work at a company called Wellthy, which is solving the caregiving problem. And that's what we're here to talk about today. So with me today, I'm super thrilled to have Lorena Rodriguez Chandler and Dr. Carla Perissinotto. They're both going to give some information about who they are, what's their background, what's their organization. Lorena is Chief Health Equity Officer at Inland Empire Health Plan, and Carla is Chief Medical Officer for Sabio Health, and she's also the Professor of Medicine at University of California, San Francisco. Sorry, it's hard to see you talk at the time. But the goal today is what we want to do is talk about the care crisis. And that care crisis then impacts families. It's caregivers who are really facing the burden. And there's certain populations that disproportionately are caregivers and are feeling the burden. And then on top of that, you now add the complexity of healthcare. And how do you navigate the healthcare system? And that's what we're going to talk about today. And what I'm really interested in is because we have a panel of people coming from different perspectives. We've got somebody from a health insurer that takes care of people, Medicaid population. We've got somebody who's boots on the ground, primary care, homebound physician, and sees it with their eyes. And then I work at a company where I am seeing stories day and day about what families are going through and the complexity and how that actually just contributes to the health inequities that we're seeing now in the United States. So I'm going to pass this over and let Lorena talk about her organization, talk about your organization, talk about your role, how you got into your current role, your experience as a caregiver, and just, give everybody an understanding of what your organization's about.
Right. And are we doing this live?
Yeah, we're doing this live if you want to stand up.
I guess I'll stand up. We're in a teaser. Good morning. Buenos dias. So good to meet you all. Thank you for joining our session this morning. I am so thrilled to be here representing, and I should probably start by saying that my pronouns are she, her, ella. And I am wearing a gray suit with a teal top and dark hair. And so, yes, thank you, Dr. Rudy, for the invitation to join this amazing panel. I come here as a representative of my organization, the Inland Empire Health Plan in California. And we are the largest not-for-profit Medicare, Medicaid plan in the United States. We serve approximately 1.6 million members, and we are in 2 counties that are Riverside and San Bernardino. I think someone mentioned to me that the geography or the space of our 2 counties is that you could fit 7 U.S. states in those 2 counties. That's how vast our region is. The majority of our membership is comprised of Medicaid or Medi-Cal in California members, and about 56 or so percent of our members are Hispanic, and a significant amount are also prefer to be communicated in Spanish. As mentioned, we also participate in the Medicare space, and we have approximately 35,000 of our members in a dual special needs program. As the Chief Health Equity Officer, I have the privilege of influencing and impacting our health equity strategy, as well as standing up interventions that we attach or tie to our inequities that we've identified. And I'll share in a little bit about one of the neat programs that very much correlates to the topic today. And again, I won't go into too much detail, but more people are coming to the Inland Empire in California than any other region. And conversely, this region is actually seeing the highest growth for individuals over the age of 65. In addition to that, and actually, unfortunately, I should say, within our 2 counties, we have the lowest population to primary care ratio. And about 35 PCPs or primary care physicians for 100,000 patients. And then to top it off, about 25% of the docs that we work with are aging out, and so they're going to then, unfortunately, we're going to see even a further reduction in our primary care physician availability. So that speaks to, again, the access that we're seeing. And then when you fold and you tie in the number of physicians that are Spanish speaking or that represent our membership, it's even more dire. So again, just to kind of paint or articulate the challenges we're dealing with. Inland Empire Health Plan just joined the exchange this year. So January 1st, we went live with Covered California. And this diagram, I think, illustrates that we've made a significant, I think, in California headway thanks to the expansion efforts in our state. We now are able to cover children and adults up to the 400 federal poverty level. I mentioned that we participate in the dual special needs program, and unfortunately, you'll see this illustrations that we don't participate in Medicare Advantage today, and this is unfortunately a gap that we're seeing. So, if you're making over $41,000, you're forced to basically select a Medicare fee-for-service product. So again, we're making headways to help address that, and is our hope and our goal that in the future we'll be able to see this diagram completely filled, so that we can address again the gaps in access. I'll pass it on.
Good morning. So my name is Carla Perissinotto. I'm wearing a very bright pink shirt. I also have frizzy hair, and I go by the pronouns she and ella as well. Mm-hmm. So I am a geriatrician and palliative medicine physician, something that sadly we should see more of in the Medicare population serving Medicare members. But unfortunately, the word has not gotten out about how amazing geriatric care is and what amazing field it is to be a geriatrician. I will also say that being at this equity conference, I'm surprised to see that, aging as an inequity is not talked about enough. It is probably one of the final discriminations that we allow. And even as we talk about COVID, we often focus on brown and black, but we don't talk about actually that numbers, regardless of race and ethnicity, were aging. And even how we were defining who was at risk was really far behind. And even how we defined how COVID affected people. We missed so many people early on because of some very basic concepts of geriatrics, which we know older adults present differently. And so that's my soapbox for the moment. So what do I do? So I'm a geriatrician and palliative care physician. I've been at UCSF for a long time. And during the pandemic and while I was on maternity leave, staring at a wall, as my husband said, which he'd never seen me do, I started thinking about what's missing for the care of older adults. And at UCSF, I ran a home-based primary care program. What was happening, though, is that many of the patients that lived outside of the reach of academic medical centers or in different health plans weren't able to receive care. So I founded a practice that I have 2 locations, one outside of Atlanta and one in Northern California, really seeing homebound adults. The difference between what I'm doing, what some other folks doing, is that many people try to think like, oh, let's see all the people in assisted living. Well, the people in assisted living are the ones that have more finances. And what about the people that are actually at home and don't have access to anyone? I just actually came back from Georgia late last night. And I'll tell you, the first patient I saw on Tuesday was 94, living about 2 hours north of Atlanta. And I took a video driving there. I sent it to my colleague in California. She said, I don't know if that's idyllic or if there's like an axe murderer waiting to kill you. And I'm like, I'm not sure yet either, but it's pretty rural. All her family has died. She is dually eligible, but she can't even find caregivers because of how rural she is. I was able to go see her. She has large abdominal mass. I was able to draw her labs and then drive 45 minutes to drop them off at the lab. And in terms of care navigating and how to find caregivers, it's really impossible. And she has no one really advocating for her in terms of how she gets the care. The day before that, I saw an 84-year-old woman who just lost her husband a week ago after being married close to 66 years. Retired teachers, don't qualify for Medicaid, also in rural areas outside of Atlanta.
No, I'm
And
not seeing
she
any.
doesn't
I'm
know
not
where
seeing
to
any
get that
questions.
help. So what we do is really think about what we all know
I
we
thought she'd
should be
had
doing
one,
is
but
doing
it doesn't.
comprehensive care. It's not me saying as a physician, I can't talk about your social issues and I don't know anything about that. It may be that I'm the only person meeting them, or it may be that my nurse practitioner is the only one. So if I say that's not my job, we miss a great opportunity to really think about how to navigate all this. We'll talk a little bit more later about some of these case studies, but I think important to think about who are actually the homebound population and how do they become homebound. Well, and a couple things about what the consequences are. So we know that being homebound or relatively homebound, people have about twice as many chronic conditions. There's increased depression, probably a higher proportion of people with dementia, which is why the new guide model is really important, thinking about how we understand dementia and caregiving for dementia. Higher rates of hospitalization. We heard this morning that we know that mobile care actually reduces utilization, but forget the finances. It's actually the right care. It's the right thing to do for people to meet them where they are. And what I see in some of the patients that I've been seeing is that the first 45 minutes that I'm talking to them is talking about the medical trauma of dealing with the healthcare system. And yesterday I walked into a visit and I was late, and the daughter was so annoyed with me. And then at the end she said, and this is for her 80-something-year-old mother, she said, no one has ever done this comprehensive visit. How sad is that is the state that people aren't getting? But there's 1 million MRIs and 1 million specialty notes, and no one's actually holding this person and this family and the caregiver distress. And I think a big part of this exactly is the stress and knowing how to navigate the health system. I'm a physician. I find it a nightmare to deal with my own health care. And then to do that for other patients, it's absolute insanity, as we all know. So that's really what we're talking about today. A couple other things. Let's see. So how do we think about this? A big part of hopefully what I really focus on is how do we actually make the homebound visible, is recognizing that these are real people, real families, real stories, and people that need outreach to. And we have to think a little bit differently and think outside of the box. It really is comprehensive care. And it's really also ensuring that we understand the care needs of older adults. I see a lot of people starting companies, but no one actually has an expertise and understanding of aging and dementia and what it means to be a caregiver. I will say that, like Lorena, I'm a first-generation American. Spanish is my first language. And so the number of patients that I see that are monolingual Spanish speakers, you add a whole level of complexity when we think about, health equity, literacy, and navigation. I have so much to say, but I'm going to stop there so we can actually have more conversations.
So what you saw having Carla and Lorena is looking at it from a population health. She's managing one of the largest Medicaid systems. And then Carla is telling you this is what she's seen on the ground on the individual level. What I want to do now, I just want to take this 30 mile or whatever, 30,000 view and say, what does the care crisis look like? And I'll tell you, it is not a snowball, it's an avalanche coming, because we have to see, we've got 11,000 adults are turning 65 every day. The fastest growing cohort is actually people 80 years and older. And that is the group that needs care the most. They need caregivers. I mean, the average older adult sees 10 doctors a year. So there's, and so who is taking care of this older adult? This is growing. And the first line of defense is your older spouse, the person who's living with the home, and they already have their own health conditions. We oftentimes see older spouses who are lifting their loved ones. So now they're at risk of falls for themselves. The other group to note is that these caregiving situations are lasting much longer, right? Because people are living longer, there's treatments. But that burden is going on the family. And I would say that the primary person who is taking care of it is women. And so women, and in my cohort, I would say all three of us are caregivers. We're all in the same age cohort. I'm lucky. I've got siblings who are sharing it. Lorena, I'm in it. Yeah. And Carla?
Sibling not sharing.
Yeah. Sibling not sharing. And if you are in the healthcare business and you're a caregiver, you are now the care expert every time. Your family's going to go to you for everything, right? And am I speaking like to the choir, right? And here's what's interesting. So caregivers experience 60% more depression, more anxiety, so more mental health issues. Working women are 75% more likely to be taking care of a loved one. So now let's see, how does that impact women? Well, the second reason that people leave the workforce is because of caregiving, the first being retirement. So for women, now you think about it, you've just put them in a financially insecure situation because they're not contributing to Social Security, they're not contributing to their pension, they're not contributing to a 401k. And nobody's thinking about that, 10, 15 years later. The other thing then is, Carla mentioned dementia. So the thing about dementia is it is the highest caregiving burden. It's 25% more hours per week than any other condition. Somebody with moderate dementia requires about 28 hours of caregiving support per week. Imagine that on top of a full-time job. And Black Americans are much more likely to be diagnosed with dementia. So now their family has a much greater burden. And all of this then you can see is contributing to the caregiver burden in disproportionately certain populations. And then the ramifications of that, also people in rural areas, much more difficult to find caregiving support. Language barrier, like both Lorena and if you don't know the language, then how do you navigate the system? So that's the, high level, some examples. So now put the complexity of healthcare on top of the burden that caregivers are already experiencing. So I just wanted to find some definition of health literacy, and you can read it up there. I won't read it for you, but what I found that was really, when I was looking for what health literacy means and what matters and what I see in my company that's lacking is taking action. It's one thing is to absorb the information and understand it. Another thing is like, what do I do with this? It's incredibly difficult for people to know, how do you do appeals? How do you make sure that you're filling out the forms for Medicaid, and so on. So let me just dive into what is complexity of healthcare. Now, I'm a epidemiologist, so I always go with statistics first, but I'll tell you stories afterwards. I mean, when you think about the complexity, our fragmented system, at least a third people say they don't understand the system, the healthcare system, at all. Hang on, let me get my notes because I can't see. And 25% in a survey done by, I think it was Kaiser Family Foundation, 25% of people say they don't know how to coordinate access easily access coordinated care. So on one hand, what I've heard today, and I one thing I can say is we have expanded access to health insurance, because one thing I don't find in all the notes and all the qualitative research is that people do have insurance, but what they have is they don't know how to use their insurance, and there is a lot of barriers to actually accessing insurance. So another study showed that in the same employer group, low-income employees had a much more difficult time understanding and accessing and understanding their health coverage versus high income. So then they're not using it right. Overall, 58% of people have reported they've had a problem with their health insurance. It's and that burden and that problem, it's two things. It's access and affordability. It used to be affordability, but access has started to come up to the top. So even though we may have, it's great. I worked in Medicaid, and so I understand the rules that you have to get, a specialist appointment by a certain amount of days. There's the new final rule that was mentioned that, you have to get primary care within 10 or 15 days. That is great on paper. But you start calling, and if let's say you're Medicaid and you're calling and you're trying to get to somebody and you can't get in, if you don't have a care advocate that says, I'll get you in, I mean, then you don't get, you may wait 4 weeks. You may wait 8 weeks. I mean, personal experience, the reason I can get, my son just hurt his knee. We went through all these problems. I was calling, finally when he got his specialist after the MRI, that was a problem too. It was 4 weeks out. All I did, I called and I was like, hi, I am going to file a complaint. And I'm just saying, like, you have to be an advocate. And you know what? I got an appointment in a week. Now, now people with language barriers, people in rural, do they know that? Do people in low income know that they have rights? And I'll finally talk about prior auths, because if you look at a study with prior auths, providers are saying, wow, this is really becoming onerous. 80% say that they've seen people delay care or just abandon because of the prior auth, process. But what's so interesting is 82% of those prior auths that were denied are approved and overturned in appeal. So it means you can get care, but do you know how to file the appeals? And that's where I think, strong care advocacy is really important. I'll give you an example. This is, I get examples every day, because I'm on this list where we read about stories. So a family member, an older adult, was wrote in a story. She said, I can't believe this just happened. I've been diligently paying my Medicare Advantage premium for years. I got discharged from a hospital to a skilled nursing facility. Now, the family lives at least 3 hours away. Day 7, they thought they had 100 days of skilled nursing facility, because the thing is, people don't understand. 50% of people think Medicare covers long-term care. It doesn't, right? So what happened was that they got the discharge notice at day 17. The family was completely unprepared for the fact that their older adult was now getting discharged home, did not have the long-term care. And that's what they said is, like, it said in the coverage up to 100 days. It's not a guaranteed 100 days. And yes, they came to us and we were going to help them with appeals, but it's understanding the health coverage, because that family was not prepared. And that is when we talk about chaos, confusion, and fear. So we do need to have, I would say, a multi-channel solution to this. I think it's at the point where we do need strong care advocacy. So a family, a caregiver, they're basically, if you took it in 3 large buckets, they need emotional support. They have to have physical support because they're doing a lot of the work in the home. That's where they need respite care and assistance with caregivers. And then it's the administrative and logistical, which is the example I just gave. They need to have somebody. It can take hours on the phone. It can take hours to get the benefit in the forms filled. We had a member who, a woman who passed away. She was in a nursing facility, and 4 years later, she got a bill from the debt. Their family got a bill from the debt collector saying they now owe $15,000 because their parent lapsed on their Medicaid. They didn't get redetermined, and at some point they lost it. So how do we get ahead of this? Because we have the coverage out there, we have the access out there, but how do we make sure that families aren't stuck with this burden because it's only growing? So that is my soapbox. And now we're just going to really, talk about last minutes, just like I gave examples. I'd love to, Carla, more case studies. What we're trying to do is just enlighten that every situation, when I see a caregiving situation, I've seen it once. It's always nuance. There's family nuance. There's family dynamics. There's financial. It's not just one thing that we are helping. We are helping multiple multiple things in a caregiving situation. So
yeah, so I think we all have so many stories to talk about here, and I think again, the framework or the position I come from as a primary care physician in the field, and also someone leading an organization trying to think about what are the models of care that we provide. I was trained as an anthropologist. Like I said, I'm a first generation American, daughter of immigrants, and so that population is incredibly important to me in terms of how do we access. And I was also trained as an anthropologist, and so my view of healthcare and health has really always been looking. Social determinants of health is not a term; it's just kind of a normal part of health. Like we don't have to separate it out. Like that is health, and it's like we shouldn't be trying to monetize that, frankly. And I'll give you one more story. Is that yesterday, and literally, so I was in Georgia for a couple of days seeing all my patients, and I go back and forth between California and Georgia because I'm insane. I have a 4-year-old at home, and I have aging mother, and then other family in Mexico that I'm also caregiver for, trying to navigate the healthcare system in Mexico. But I saw a 65-year-old woman, monolingual Spanish-speaking immigrant, who is dually eligible, schizophrenic, epilepsy. And when I saw her for the first time this year, no one had actually recognized that she had cognitive impairment because no one had actually bothered screening her. And she was going to the hospital repeatedly. Why? Because she had like 5,000 medications, which is a common thing that I see. And so I think much of what Ellen said with people seeing 10 doctors, what I try to do as a geriatrician is despecialize and get all these people out. Maybe it's a little bit of my controlling nature, but it's partly because I see this fragmentation that more is not necessarily better. But sometimes if we simplify and go back to some very basic things. So what we're talking about here in terms of literacy and access and caregiving, there's a lot of complexity, but we as a country are introducing complexity rather than going back to some very basic things. It means that part of my visit yesterday, yes, I'm a physician and it shouldn't just be me and I should have other team members, and I do. There is a part of a role as a clinician that you need to understand all aspects of someone's care. So me reading through her letters that she doesn't understand because they're in English, saying that she needs to get her Medicaid redetermined is incredibly important. If I don't know that as her clinician, and if I can't help her navigate that, then that's a problem. And I think much like Ellen says, sometimes you do need an entire team, but sometimes it's just providing that person with someone who speaks their own language, novel concept, and making sure she knows that we're there and she can trust us. So much of what is going on in healthcare is because people do not trust the provider that they see, right? And once they know that they can trust you and that you are there, you can hold a lot more together. That doesn't mean I can do everything. I think there's absolutely a role of when I do reach out to my health plan partners and say, hey, do you have a transportation benefit that I didn't know about, right? Do you have this? And very often, and sometimes it's the health plan directly, or sometimes it's going through a Medicare broker that can help me navigate what does this person have that I'm not actually aware of it. So, what I see every day is these things that, it's so sad that very basic rights and equity founded in the Civil Rights Act about language access and equity are not there every day. And I struggle sometimes. I have another patient in San Francisco who's 91 with spinal disease. I sent him to a specialist, unfortunately, because I couldn't inject his spine. And when I called and said, hey, he's a monolingual Spanish speaker, and they say he needs to bring his own interpreter, and I almost I lost it. And I was like, let me just calm down, because I was worried that if I threw a fit and made a complaint, they weren't going to see him. But that we know that is illegal. And yet it happens every day. I'd like to think that I'm smart, but I'm not that smart. What I do and what my team does and what my group does is actually meet people where they are, communicate in their own language, and make sure that we are a reliable, trusting person. And no tech company, no little thing can do that. And I think that's what it's doing, is getting back to some basic things.
Yeah. And I think, thank you for sharing. Again, I come from California, and we have what's called CalAIM. I don't know if many of you are familiar. And I mean, I'm just so grateful that I am at the organization that I'm at. And we were just sharing last night, working for a nonprofit health plan truly, I think, makes a difference. And it was a culmination, accepting this role as Chief Health Equity Officer. A lot is on my shoulders, right? We have 1.5 million members, as I mentioned. And, to see that, we have such vast geography, this is where our community health workers truly help, right? Where we have that collaboration, that wraparound services within our CalAIM program, we're able to offer what are called community supports, right? And I think what's really important, at least from my point of view, as, the daughter to two aging parents who are also monolingual, I've been the caregiver since I was probably 9. And I'm not kidding when I say that, in that I accompanied my parents to their doctor's visits when I was a child because of language barriers, right? I interpreted for them. And it was at that moment that I realized something's completely wrong with our system. And I took it upon myself to enter the healthcare world. And although I've, been with on the health plan side primarily, this role as health equity officer truly is a culmination. And to be able to leverage, again, all of these different support programs that the state of California thankfully offers to Medicaid beneficiaries is truly, I think, we're making headways. It's slow, but we're getting there. And again, rural communities that we serve, we have community health workers pairing with nurses that are actually going out to regions that are 3 hours away from our corporate office, right? And seeing patients that are farm workers. I was just there was a story that one of our nurses shared with me, that there is a region where retired farm workers live, and they went and conducted a home visit, and this poor gentleman does speaks Spanish only, is not able to read or write, and he received a glucose
Commoner.
yes, and could not read it. He did not know how to use it. And thankfully, these folks were able to go and intervene, speak with the caregiver, the daughter, and be able to, again, bridge that divide, connect this gentleman to providers and other resources, that are available. But those are the type of kind of creative, strategies that we need to think about, right? Is to support the provider. The onus shouldn't necessarily be on you. And again, just my mom, just recently was diagnosed with a condition, and is now under the care of a palliative care physician. And the entire family came to me and said, okay, what does this mean? And now we're having to help my mother try to understand what's happening, right, with her health condition. I'm actually going to jump on a call with this doc at 3:00 today, to find out, what are the next steps? What does this mean for mom? So yes, this is a reality that we live in.
So, and we'll do questions at the end. So what you're seeing is, we're talking about the case studies, and we're talking about how solutions. And I really think that it does require, all of us coming from different industries to solve this problem together, because, you're talking about providing language. My company, is sitting a little bit higher. Like, we are basically telehealth social workers, and we're seeing sort of this complexity at levels of trying to get care. We oftentimes get asked, I need a caregiver who speaks this language. And on top of that, how do I know that whatever caregiving organization I'm using is reputable? Because that's a lot of concern out there, is this fear of, I don't know if this organization's good. How do I pick it? I had a friend whose wife was diagnosed with early onset dementia. And he, about 4 years in, he spent, it was at a time he actually needed, full-time care. And he spent whatever, a couple days researching. He's not in the healthcare industry. And when he finally picked this caregiving organization, he told his nurse, and they're like, "Oh, that's a horrible caregiving organization." And he just didn't know where to turn. And so when you talk about trust, one of the things that an organization, a company like us, a caregiving support company, is that families trust that. They trust that organization. They trust our organization. We are not the health plan, and we are always there. We are following them on the care journey, because one of the most frustrating things a family can experience also is you've got this incredible care crisis going on, and then you call and you have to get another person that doesn't know your story, and now you've got to repeat your story. That happens very often with children with complex needs. That's probably one of the most frustrating areas. But if you have one person with notes, that is like your case manager, because not everybody gets case managers in the healthcare system, right? You have to be high cost typically to get that. But really, when you think about it, how do you step back and provide that care sooner? You help people understand their benefits sooner, and then you're there for them when the crisis hits, because that's the way caregiving works. It's going along, crisis. I need help. And that's where, so when I was thinking about it, and I sort of spoke before I asked the question, but how do we come together and contribute to playing a role to help solve the problem? Because we've talked a lot about the problems, but let's now come in and talk about the solutions. And so that's where we can step in. We are a caregiving support company, and we can be that support system. So I just wanted to, Carla, how do medical providers come in? What is their role, and how can they support caregivers and really help with this care navigation?
Yeah, I'll start by, this is not the problem we're going to solve today, but there's a primary care crisis, clearly. I mean, I spoke to a daughter 2 days ago that her mom's they're in the middle of a crisis, and they're like, we're at the point, we don't know what to do. My mother's in assisted living. She's having dementia crisis, and we got a list of people. And the first thing people assume is when I make home visits that I'm concierge. And so, as I tell them, I said, to my financial detriment, I am not concierge. So I am getting my rates that I'm getting, but it is the right thing to do. But it happens to be that I actually have expertise, unlike many of the concierge practices that go and see older adults and don't actually have expertise. So we do have a primary care crisis, and that's another topic for another time. But I think once we are there, I think, what do we do? One of the things is when we talk about complexity and coordination, it means actually doing that, because what we're seeing is a lot of different pieces and nothing's actually coordinated. So it means that, Ellen, if I work with your team, it has to feed back. Yeah, right. Lorena, if I have one of your team members, it is not helpful to me to get home health if they do not call me. That also means that for my physician and clinician colleagues, it means you have to return damn phone calls, right? I think when I talk to home health, they're like, you actually pick up the phone? I'm like, that would be correct. I actually want to know what's going on with my patient. So there's a lot of things there. So I do think at the center of this and what we do is truly ownership, which doesn't mean attributed. It's not that my members are attributed. It's mean that I actually truly own the whole clinical picture, which means that part of my job as the clinician leading the clinical team is talking to my community health workers, is making sure that door is open, is talking to Wellthy. I will say that also, truly understanding aging, it is different. Our current healthcare systems are not catered to older adults, and we need to stop ignoring that fact. And so part of that, and that's what gives me hope. I think we may be talking about hope, but I'm going to say that part of what gives me hope is that I think we're starting to enter and recognize that we can't continue to ignore this. And so there is some really great positive change happening there.
I think from a health plan perspective, it's super important. I think from the beginning, when you're onboarding a member into the plan, identify who that caregiver is, right? It's incredibly frustrating for me to navigate, even with, advanced directives and everything else, to speak with, physicians. I am the keeper, basically my parents, entitled health history. But I think it's so important to be able to, identify me as a caregiver for parents, communicate with me whatever information you're sending to my parents, send to me as well, so that I am aware of what's happening, right, with their care. And if I happen to also be, limited in English, and I've shared, I prefer this, material in Spanish, again, cater to that caregiver, embed that caregiver in that journey that your member is in. So I think from my perspective, I know that that's something that we're looking to do within YAHP.
And when you mentioned about the coordination or making sure that people in the family know what's going on, that is one of the things that we found in our company that's so important. It's how you create, we call it creating the care circle. How do you make sure that everybody knows what's going on and that the caregiver knows what's going on? And how do you keep all this information? You get a massive amount of information depending on the condition. You get PDFs sent to you. You have advanced directive. You have medications. How do you create a platform that is user friendly for the family, right? If you get case management from Medicaid or Medicare, the family can't go on to that case management system to see what's happening, right? So then they're a little bit like, what's going on? What's the status of XYZ that I need? I think that's like helps with really that coordination, is really giving families the power to be able to sort of know what's going on with the care of their loved one.
It's funny. I almost think, like, even though I've been saying, like, we need to trust the healthcare system and provider, there's another part that our patients need to know, not to trust it. And what I mean by that is that so many patients that I see, especially the lower literacy ones, think that everything's in the record. Read my record. I'm like, you have no idea what that means, right? I just saw a monolingual Spanish-speaking couple also 2 days ago. It's very interesting. My population in Georgia has turned out to be even more diverse than in San Francisco, which is fascinating to me, which is very cool. But the son was like, well, here's her medication list, because he assumes that the one from the hospital is correct. And then I'm like, this is not what you have going on here. And so that's where the power to say, like, you give people the authority to question physicians, including me, and to really own their health and their story.
Yeah. In fact, a lot of the caregiving support we do is teaching people what to ask when they go to the doctor.
Yes.
It seems so simple, especially if you're in healthcare, but families don't know what to ask. And then you've been to this appointment, and then afterwards you're like, oh my gosh, I'm supposed to ask this and this.
Yes.
So
Exactly.
teaching them ahead of time also is really important. We're almost up at time, so I want to give hope. There is hope because because I do see like legislation coming through. I mean, for instance, just recently they passed a bill that said caregiving is now not taxed. I don't know if you realize that, but if you were an employee and you received caregiving benefit through your employer, you got taxed on it. And so what happened is lower income people were like, I can't, people get scared. That is now, gone. And we've seen in our clients that we're seeing like people start using it more. So that, people are recognizing it. And Carla mentioned the guide model. It's a CMS innovation to support caregivers who are taking care of somebody with dementia. They recognize the value of caregivers. If we didn't have informal caregivers in our healthcare ecosystem, it would collapse. And they are actually in that, which I thought was really interesting. Depending on your criteria, they're giving a respite care allowance for the first time. So that gives me hope. And if let's test it out in CMS in the innovation, and maybe that, pilot will teach even Medicare Advantage that you should provide this type of extra support. Because that's my hope, is that, we work a lot with employers, but I think we need to work with Medicare Advantage and Medicaid plans and just be that extra support for families. So right on time. So anyway, now I'm going to open up to any questions.
And I think I'll just start with one virtual question. There are third-party care navigation services that partner with insurers and have access to claims data to provide the healthcare navigation and advocacy for the member and the clients. Have you seen much success in this for these programs, and how do you measure its progress?
Carla or Lorena?
I again, going back to just kind of my CalAIM experience, I think again we've got a comprehensive team of nurses that are taking care of our members from transition care, and again incorporating the CHWs, the community health workers, into that fold. Assessing burnout too is another. I meant to add to some of the recommendations is assess caregiver burnout, right?
Mhm.
And provide respite care or support. And I think that again, to our benefit in California, and my hope is that this is applied to other states in the nation, is that we're able to incorporate all of these different supports into the experience, the members' experience.
I think to add, there's a lot out there talked about. I think when it actually comes to the details and really on the ground and implementation, how it works, I think it's still not clear exactly how all of this work. Again, we're often introducing a lot of complexity and more fragmentation rather than coordination. And I think that's the danger that we're in.
Yeah.
So unless there's truly more transparency and really collaboration, I have a hard time seeing how this all works.
Yeah.
Question?
I thank you all for your perspectives, and I am gratified to know that the issues surrounding caregiving and that impact caregivers are becoming more and more understood by various parts of the healthcare system. But to my mind, the biggest equity issue is that we are not paying for long-term care.
Yeah.
And it's an issue for the people who need long-term care and must have polished themselves to get on Medicaid. It's an issue for their caregivers as well. How do we harness this greater awareness of what's happening across all slices of society? I mean, people across the board are dealing with this. How do we then turn this into, how do we create an insurance system that actually supports the needs of the people that we're trying to serve?
Mm-hmm.
So I'm going to go a little bit bigger to answer that question because I don't have the answer. But I do think that, and I sometimes sound like a broken record, but until we truly address ageism as an equity issue, I don't think we're going to solve this problem because we continue to want to just close our eyes and pretend it's not a problem. And so I think that's where, Ellen's role as an epidemiologist to really put more of these numbers, but in figures and really think about, or until some of our legislators are dealing with that or have direct people where they're experiencing it, I don't think we're going to see a change. But we continue to accept substandard care for older adults. And also our long-term care systems are not exactly, one of my monolingual Spanish-speaking patients who lives alone right now, kicks out her caregiver every week. She was in tears when I mentioned to her that her family wants to move her to a nursing home.
Mm.
So it's also, how do we define long-term care? Because most people don't exactly want to go to a nursing home. And those that do, I'm a little bit worried about what they came from, that's a positive thing to do.
Yeah.
Yes.
And so,
But yes.
how do you solve this? It's always about incentives too, right? It's who makes the decisions and what's the incentive. So Medicaid population, interesting, right? If you're a dual, you're on Medicare and Medicaid. You would think, and this is what I learned, and I'm not an expert on exactly the payment structure, but you would think if I help keep your member in the home longer by giving you more home and community-based services, you're going to save money because they won't go to a nursing home because the nursing home is the most expensive. But actually, that's not quite the way it works right now, because it's the way the payment system is. You get, the finding, they look at what your costs were 2 years ago. So if your costs go down as a Medicaid organization, you might actually get a reduction. So you need you got to create the incentive structure, right? Where, if I provide respite care enough, and that keeps you out of a nursing home. And let's say, on average, there's some studies that say if you do it right, you can save 9 months of a nursing home. Then the incentive should be that the health plan, gets some of that money, because that's what's going to drive. That's the way the system is. Like, what's the incentive structure? And I think, and I think you both spend it. If you're on Medicaid, you actually get the long-term service part. It's the group, right? Really right above it. That's, I think, the most at risk in some ways.
Yes.
If you're wealthy, you can pay for it. But if you're on a pension, like your patient who gets a teacher's pension,
I mean,
I think that's where we have to really think about in that discussion. And it's, I'm glad it's being discussed. And I think it's going to need to be more discussed.
And I also say that it's sad that we have to think about what the payment structure is, that it's not just because it's the right thing to do. So
yeah.
I agree.
Only because I want to, obviously this resonates with everyone in this room, but because you brought up legislation, is there any move to change the language of Medicare and Medicaid to plain language so that people can actually read it and understand their plan?
CMS.
CMS. Yeah. One day, all of a sudden, I was caring for my elderly grandmother who had no one else, and I'm a nurse practitioner, Pete, so the opposite of the population. But of course, I love my grandma. But even myself, like on the phone with people trying to understand what she's covered for. Thank God she is in a long-term care facility and she is covered. But I just thinking of my own experience, is there any talk in Congress trying to make things easier for people to read, not even adding additional languages onto that?
Can I tell you that actually with my patient with schizophrenia, I didn't understand the letters she got from Medicaid. I mean, I had to read them like 10 times to understand that meant that she was losing her Medicaid and need to reapply. And that was really scary because she was trusting me to understand it. And I'm like, it took a little bit to be like, oh, you need to reapply. And Georgia is very different than California in terms of Medicaid benefits. So that is a whole nother.
I live in New Jersey and she lives in Pennsylvania. So really
Exactly.
Yes.
Again, the communications are highly regulated, right? From a health plan perspective.
So you heard it here.
We're confined, by what we can communicate. It's pretty much spelled out for us. And then you have to then translate into, different threshold languages. So CMS,
Who's listening, who's taking notes.
Yeah.
Hi, thank you all very much. Quick question on sort of like maybe this is for Inland Empire Health Plan specifically, but I think, sort of the decisions that get made about what products, what specific medications, what specific services get covered by a health plan, whether that's a private plan, whether it's a Medicare Advantage plan. That's really a health equity issue because there are certain services, certain products that work better for certain populations than other populations. If there's a certain population that has more of a co-occurring disorder, for example, certain products might work better for them. How we kind of integrate health equity into sort of those types of decisions, because I think a lot of folks don't really understand how, they call their health plan and one brand of a medication is covered and not other when their doctor specifically said, I think this brand's going to work best for you.
Mm-hmm. Yeah, again, I think another very, very difficult question that's, we're confined by, the parameters, right, within either our state or federal kind of guidelines. I know that we recently participated in the VBID with CMS, value-based, I think it's insurance design. I should know this. They incorporated a health equity plan in that program this year. And we got creative with our Part D, offerings as well. And I think that that's kind of a step in the right direction. But again, it's going to take so many different, components.
And I think to answer that too, I think that's what gives me hope is that, it's a little bit sad that we're all late to the game to actually talk about these things and people respond differently to medications, or that I have to write this passive aggressive response back on the prior authorization. Not passive, it's actually pretty aggressive. But I think the fact that there's dialogue around this, even as we know how we categorize chronic kidney disease in African Americans and what that changes in terms of medications and transplant, we're making progress. It just, it's like 50 years too late, but we're getting there.
Yes. First, thank you so much for the work that you're doing. And I hope you're all finding ways to rest, because this is a lot to give in terms of energy. So thank you so much.
Thank you.
And this is actually
I take massage donations.
I think all of us here can say we don't have that kind of income. Okay, so definitely personal, but like for the donut hole. So my father unfortunately has not advanced, but like mid-stage dementia. My mom's his sole caregiver. My sister and I try our best, but of course they earn too much for any type of respite, and it's like, where do we begin? Because like I'm constantly navigating. I literally came here, so like I need advice so desperately for my poor family, and I'm sure I'm not the only one. And also, cultural relevancy is incredibly important, and that is honestly fundamentally lacking where anybody who is, not in an area that has like a high concentration. Like for myself, we don't have anything relevant for the Indian American community, and it's frustrating. My father speaks English, but like he'll go to places and we'll be like, oh, behaviors we don't do. And so like anybody in the audience have any recommendations for Massachusetts trying to navigate like care, respite care, literally anything that isn't going to bankrupt my poor family? Like I don't know. And also we have used Wellthy. Thank you so much. You have really helped us. But just like curious if anyone has stories on like how to try to get it, because it's infuriating. Like I hate that all of us here recognize that we don't understand the stuff that we're in. And that's like a very sad state of affairs, in my opinion, because we're trying so hard. And if you're like, I can't read this letter and you're a provider, goodness, what hope is for the rest of us? So anyone have thoughts, advice, anything?
Honestly, I think, and to the detriment of my resting, I'm happy to talk later if you'd like to about your father. But this is where Guide is really exciting to me, actually. And so, it's starting in July for existing programs, next year for new programs, and depending on what he's on, if it's traditional Medicare, this is exactly what Guide is for, is to really have that comprehensive, have the respite. I mean, this is what we're looking at. That doesn't solve the problem today, but I think that's in the process. There's also great other novel programs if you're dual like PACE programs. But and I think you mentioned something about the donut hole. I think one of the things that we forget to talk about, and again, sometimes a one-time consultation with a geriatrician or someone who's geri-minded to really look at pharmaceuticals, is there's so much extra prescribing. Suddenly you get rid of all this stuff and you're no longer in the donut hole. But there's someone. Yes.
We do. She's amazing.
20 minutes later, you're like,
I know.
For you. 2 minutes. Okay.
Thank you so much. I'm from the Center to Advance Palliative Care, and we work on these things on a daily, minute-by-minute basis. And I'm going to get provocative because I do so appreciate everything that is being developed to help caregivers, but it's on a broken system. And I am concerned, even that question from virtually, the more funds and attention that goes into helping people navigate is taking away a focus on the fact that, like people have been saying, we shouldn't have to navigate this. And we're sitting here and I have all my stories too of I can't figure this out myself, and this is what I do. So I guess I just wanted to ask you, I don't know if it's like a national day of strike where every caregiver in the country just says screw it. but I don't know how to make this happen, but I just feel like there's such an imbalance of power, and I do appreciate you're helping people, but there's got to be a system change, and I don't know how to start.
I want to say first, thank you to CAPC. I'm a member and so appreciate all the work that you do to speak to people with advanced illness, and actually just assign my team some of the trainings from CAPC. I appreciate that. And I think provocation is what we need to do. And otherwise we don't change the status quo. And that's why, in part, what I said earlier, it's almost going back to the basics and going back, because we keep solving the wrong problem. I mean, that's how people get polypharmacy, right? You get the side effects in a medication, and that's what we're seeing is increased complexity. But that kind of solution is going to take time, right? So how do we do it in the meantime? And that's what's hard, and that's where I think we do need some navigation. But yes, I mean, the fact that the time is up. That's it. I'm not so. So the fact that we have to deal with the complexity is really sad.
You have time.
Want to share a resource really quickly? I'm sorry, I'll take 2 seconds. I work at
another federal agency called the Administration for Community Living.
Yep.
And they already know about this, but the funds are
resource center called Elder Care Locator. Just so it won't solve all the things that we're talking about here today, but if you're working with caregivers and you don't tell them about that resource, it's really great. It connects to a lot of resources that we've been talking about today. Thank you.
Thank you.
I have one question, make statement. And I do agree with your statement about ageism. I work with folks regarding dementia intervention in Georgia. Very difficult population. Part of ageism, if you look around most areas, 85 and older is the aging population. So if you have a provider that is not age sensitive or cognitive sensitive, you have a choice. You start looking for a provider that is open to listening to you as a caregiver. You are the majority. You talk to your legislators. You start writing letters to state, I need age sensitive care. And it does make a difference. So I always say you have a voice. You go out, and if this is not available at this site, you look for someone who is age sensitive and cognitive sensitive, and it will find care.
Thank you.
Thank you.
Well, we are at time. I just want to thank everybody for giving us the opportunity to talk about this today and for sharing some of your stories. Really appreciate it. Really appreciate everybody.